Welcome, everyone. It's Tuesday, November 18th. Welcome back to our Lunch and Learn. We're glad to have you with us today, and I'm particularly excited because we're going to be talking about a subject that I think is really critical, and that is medications that can be a pretty tricky business for folks who are aging and have intellectual disabilities. We've got a great speaker for you today. Cheryl's been with us before. We're excited she agreed to come back. A couple of housekeeping notes. If you have a question, don't need to wait till the end to enter your question in the Q&A box. You can see on your little toolbar there, it says Q&A. Feel free to put your question in at any point. We will probably wait till the end to take questions, but feel free to type it in there at any point so it'll be in the queue. Reserve the chat box for people who might have questions on a more technical or internal sort of note. Your questions regarding content go in the Q&A box. Everyone is muted by default, and because we're in webinar mode, we're not showing anyone's cameras. It can get very distracting when you have a lot of people and all their little screens showing. So we do not have cameras on for anyone. We will unmute you or ask you to unmute yourself if you do have a question and we want you to provide additional information for us. Again, I'm Catherine Pierce, Chief Operating Officer for the NTG, joined by Dr. Kathy Bishop, who is chair of the NTG's Education and Training Committee, and our speaker today. And I will let Cheryl introduce herself when we get started here. But she is a wealth of information and knowledge, and I know you're all going to learn a lot. So with that, I think most people are probably in from the waiting room. So I am going to stop sharing this screen and start sharing Cheryl's screen. And let me get it going in slideshow here. So there we go. Take it away, Cheryl. I'm going to let you introduce yourself first, though.
All right. Hi. I hope everyone's having a great day. We had PDR that ran a little longer than usual and a little hectic start to this. So had a few difficulties with technical stuff, but the talk I know. I have been doing this since, gosh, 2009. Worked for an independent pharmacy, and we got our first IDD facility contract. And I had done skilled nursing auditing in the past, consulting, and so they pulled me from what I was doing at the time. Working for the company was more hormone consulting, but anyway, so and they said, we need you to come handle all the consulting stuff. So I thought, well, okay, no problem. I've done skilled, but it's a lot different. So totally different, patient population, but anyway, it's been an experience because the IDD patient population, there's nothing, we don't do studies on this patient population, so it's more difficult to find medications and dosages and all that good stuff. But so I just had to live and learn, and I mean, a lot of reading. And I have found over the years that it's actually really good. The best literature I find is from, oddly enough, our countries like Great Britain, Australia, Canada, all the countries with social health, social medicine. And so anyway, I will find a great deal of stuff, case studies and that kind of thing that have helped us over the years. And it's there are a lot of problems that go along with meds in the aging adults, with IDD in particular. Honestly, with aging adults, period, but with IDD, that adds an extra layer. Next slide. All right. so the IDD population, what makes them so special or different? They age earlier and differently than the normal population. They're usually you're dealing with multiple disease states, which affect both the liver and the kidneys, so that affects clearance and metabolism. Um, and a lot of the medications that we give them over the years just add, insult to the liver and kidneys. Some of those medications are anti-seizure medications, antipsychotics, and, just honestly, sadly, the IDD patient population has fewer functioning brain neurons to start with. So anyone anyone who ages loses brain cells, brain neurons over the years. And so if you have fewer to start, then that just puts you at a greater risk. And also there's the problem of lack of exercise. So when you have lack of exercise, you have obesity, and with obesity, that affects the way that drugs work in your system. And it, also comes along with more comorbidities and diseases, unfortunately. Next slide. All right, the IDD population and pharmacokinetic process, or ADME for short. This is just some principles of just metabolism and just basically what happens to the drug when it goes into your system and leaves. Eventually, absorption. So absorption is the first step. The bioavailability of a drug is the amount of the drug that actually reaches the bloodstream. So as we get older, that absorption is affected. A lot of people have less acid in their stomach. Some drugs need more acid to be, absorbed. So that means you've got less drug that's going to get into your system. Volume of distribution is basically just the propensity to either remain in the bloodstream or to redistribute in tissue compartments. So, is it in the bloodstream? Is it in the tissue where it needs to be to do the job? Metabolism, that's just the breakdown of the med. And that changes over time because of, body changes that we go through when we age. And excretion is just like it sounds. How does the drug leave the body? Maybe through the kidneys, and which is in most cases, but, so if you're adding, if you're having more and more drugs that are excreted through the kidneys, then the kidneys over time are going to just basically get worn out. And next slide. All right, so factors that affect absorption. I kind of hit a few of these just a minute ago. There are food. Food has a big a great effect on a lot of meds, like supplements like calcium, magnesium. Those things can block some medications, particularly antibiotics. I don't know if anyone's familiar with like Cipro. That's one that comes to mind. Says, don't take it with dairy products or milk. Well, milk is a dairy product, but anyway, and that's because of the calcium in the dairy products. High fiber foods can affect the rate of absorption. They can delay it. Drugs that, like I said before, that influence the gastric pH. So if you're decreasing acid in the stomach, then a lot of drugs aren't going to get absorbed to the extent that they need to. And then drugs that promote gastric delay, GLP-1s. I don't know if anyone's familiar with like Ozempic and all those things. All those decrease gastric emptying. So what happens is, drugs that it's going to affect some of the drugs that you take, some of the absorption, and you're going to get less med into your system, or it's just going to take longer, to get it into your system. So anyway, this is just some of the things that have, an effect on how we get that drug, first of all, into the system. Dysphagia if you're having trouble swallowing, then that's a whole nother ball game, because there are a lot of meds you can't crush. Um, so you got to figure out, how do we get this drug, into this person? And thankfully, there are a lot of capsules and meds that we can just open and sprinkle onto foods and that kind of thing, and also liquids, for someone who has dysphagia. But there are a lot of factors that affect absorption. So that's just the first step in, getting that drug into the system. Next slide, please. All right. How does aging affect distribution? All right. So you have the older you get, you lose muscle mass. And what does it become? You get more body fat, unfortunately. So there are a lot of meds that are water soluble, that have increased serum levels and may result in toxicity. So these are drugs like, I don't know, gentamicin is an old antibiotic, but it is still used. Digoxin for the heart, alcohol, cimetidine, all these things are affected because of the changes in distribution of body fat to body water. Um, so, and if you're not careful, you have to give lower doses, because if you're not careful, you're going to have toxicities. And that's why, we do drug levels like on digoxin. The older you get, alcohol, you can't handle it quite as well as you could when you were younger. And then cimetidine, Tagamet is one we don't use a whole lot anymore, but and the reason being, there are other drugs like famotidine and that just don't have that aren't as risky to use. Then you have some lipid soluble drugs. That means, how is it dissolved? These are drugs that require fat. Okay, so diazepam, phenytoin, which is Dilantin, statins, the quinolones, which, like I mentioned before, Cipro, Levaquin, those are some examples of those. What happens is that the half-life is increased. Or because of because of more fat. So it takes it longer, in other words, to get broken down. So a lot of times you have to adjust the dose, period, when you've got, older folks, and particularly like if you've got kidney issues. But anyway, that's just some examples of some drugs that are affected by the changes in distribution in the aging population of the ID patients, and really of any aging folks. Next slide, please. Okay, how does aging affect metabolism? Well, okay, first of all, I mentioned earlier, liver, metabolism decreases with age. That just, you use the liver every day, all the time, you're gonna just, eventually you lose liver, cells, and they don't regenerate. So, you typically, the ability of the liver to metabolize typically decreases by 30 to 40% in the aging population. But, metabolism does vary from person to person. Everyone's different. Some people have better muscle mass. Some people haven't added all the insult to, of injury to the liver. So some people, so this is not a one size fits all, but this is just like a generality. Then you have decreased hepatic blood flow. That's the ability of the liver to, it's just the blood flow in the liver. And that decreases by about 1% each year from age 30. So all this affects, how you're going to clear a drug when you get it, how you're going to break it down and get it, where it needs to go in the right form for your body to use it. You have lower serum protein levels, so that results in more unbound drug, which results in more side effects. Next slide, please. Okay, so some of the medications that are affected by decreased metabolism, pain medications are a big one. These are all the NSAIDs, the diclofenac, ibuprofen, and then you've got meperidine, which is Demerol, morphine, naproxen's another NSAID. These drugs actually, you need to look at using lower doses in elderly because of the decreased metabolism. So you don't want it to build up and cause side effects. Some of the cardiac medications are there. Some big ones, amlodipine. Let's see, nifedipine. I think y'all have probably heard of verapamil, warfarin. Huge. Warfarin's a problem, and even without the aging population, you have to do levels because you don't want sorry, I'm not where I'm going with this, but anyway, you can get lots of problems, and even more so with the elderly. Okay, benzo's another one. Benzos can cause huge problems. Benzos can cause falls, confusion, dementia type symptoms, and all because it's hard. I don't like to use benzos period with the IDD population, but you do have to at times. Trazodone's a good alternative, I think, to benzos. It's an old drug, but it's still it has some great calming effects, anti-anxiety effects. But even though it was one of the original antidepressants, really, and kind of fell by the wayside when all the benzos came about. But even with it, you still have to use lower doses. With elderly in any population, I advise go slow, or start low and go slow. So start with the lowest possible dose you can, and then increase slowly. That way, you can help avoid side effects. Next slide, please. Okay, other factors that affect drug metabolism. I'll just hit on these real fast. Genetics. I don't know if y'all have heard the terminology. There are poor, intermediate, normal, rapid, and ultra rapid metabolizers. There are actually genetic tests that we can do that tell us, how your body metabolizes a certain class of drugs. And it's helpful if you can do those. Gender, male versus female, there's a big difference. Males have more body mass or muscle mass, sorry. Disease states, like I hit on before, if you have liver, kidney disease, or heart failure, that's going to affect drug metabolism. And then dietary factors, smoking, alcohol, consumption of other meds, all that plays a part in how the med is going to be metabolized in your system. Next slide, please. Okay, kidneys. How a drug is excreted or eliminated. The kidneys, there's something called reduced glomerular filtration rate, GFR for short. That's your kidney's ability to filter the waste and excess fluid, and that includes drugs. Okay, so as you get older, that it reduces, it gets reduced. It's not, you're not as effective at getting rid of excess waste as you were when you're younger. Decreased renal blood flow adds to that. Impaired tubular function, that's just the kidney's ability to reabsorb and secrete substances, including drugs, and then slower excretion, which leads to higher concentrations in the body and possible toxicity. So all this is affected by just aging, of the kidneys. And or like I said earlier, some medications that just add insult to the kidneys, and that affects all of this. Next slide, please. Okay. All right. IDD and pharmacodynamics. All right. First of all, pharmacokinetics. What is pharmacokinetics? I know y'all have heard that term, or maybe have heard that term, but it's basically the study of the effect the body has on the drug. Pharmacodynamics, on the other hand, is the study of the action that the drug has on the body. So we have changes in receptor sensitivity as we get older. The sensitivity of receptors to drugs can change with age. That can potentially lead to increased or decreased responses to medications. Sensitivity of receptors to drugs can change with age, potentially. That can lead to increased or decreased responses to drugs. That's the homeostatic mechanisms. Pathological changes can also lead to increased or decreased responses to drugs. And organ function. As we get older, our organs just don't function as well. Changes in organ function, like liver or kidney, as I've said before, can affect how drugs are metabolized and eliminated, and alters their effects on us. Next slide, please. Okay, then I'm sure I'm not going to go over all of this, but I'm sure everyone has heard of the Beers list, or I guess you have. Back in 2023 was the last update. This is just a list of drugs that are potentially inappropriate or for the elderly. Some of it is drugs that you shouldn't use at all. Some of it deals with drugs in certain disease states that you have to be careful with. Others deal with doses, of the drugs. But it's a really good tool to use to see if, when you're looking at an IDD patient's meds and you want to see how many meds are on this list and what can I do to maybe, eliminate some of these drugs. Next slide, please. I think I just have some, yeah, and this is just, some examples. It's pretty small, so it's hard to read, but I just wanted to put this in here just so everyone knows that this is a good tool to use. Next slide, please. Okay, and Catherine says she's going to put the link in the email in the recording, so that's great. So y'all can pull it up and read it for yourself, see what it's actually a really good tool. It really is. Next slide, please. Okay, and that's still Beers list. You can keep going, Catherine, until, okay. Oh, this is an excellent tool, anticholinergic burden scale. A lot of times, we've had this in PDR a lot, which is psychotropic drug review. That's where we bring our IDD patients in, and we have a team of behavior analysts. We have the psychiatrist, myself, nursing, the staff from the facilities, and we all, look at the meds they're on, look at the, how the patient's doing on that particular day, and decide, if we need to change something and what we need to change. Well, this is one very helpful tool, because a lot of times someone will come in and everyone thinks they have dementia, and because they're confused and they're just showing all the signs of dementia. And I look at their list of meds and I'm like, no, oh my goodness, this is very anticholinergic. Anticholinergic drugs block acetylcholine, which is used for function, focus, that kind of thing. And so when you have a lot of anticholinergic meds, you're going to have a lot of confusion. I like this scale, and I use it a lot for my IDD patients, because it's amazing how many times people think it's dementia, and it's not. We get them off the meds, try to put them on something that's less anticholinergic, and suddenly they're back to normal. So this is a big deal. So if we could include this also in the link, that'd be great. All right, next slide, please. Okay, dementia. All right, Alzheimer's dementia is progressive and neurodegenerate, and you get neurodegeneration. You get a gradual decline with Alzheimer's, and it occurs in 5% of 71 to 79-year-olds, and 37.4% of 90-year-olds and over. So acetylcholine plays a crucial role in memory and learning. Cholinesterase inhibitors increase acetylcholine levels by blocking acetylcholinesterase inhibitor, or excuse me, enzyme from breaking it down. So anyway, this is acetylcholine is huge, and I hit on that when we talked about anticholinergic meds, because that gives you less acetylcholine. And if you've got less acetylcholine because of the dementia, the last thing you want to do is add a med that's going to decrease it even more and make them even more confused. As people with IDD age, they're at a higher risk of developing dementia. In fact, individuals with Down syndrome are particularly at risk for developing Alzheimer's due to a genetic link to the disease. So they actually have a gene for it. And so that, a lot of our Down syndrome patients start developing dementia, some in the 40s, but 50s for sure. And so it's a real thing. It's that's, and then when that happens, you got to look at their meds, you've got to look at a lot of things to try to help them have as productive a life as they can. Next slide, please. All right. Okay. Delirium versus dementia. Okay, what is delirium? Delirium is like, I'll give you an example, like when we're in PDR and somebody comes in and they say, oh my gosh, this patient has dementia. They're all of a sudden having all these problems, and, and it's sudden is the big thing, sudden and acute. You know what? A lot of times it is with the IDD patient population, a UTI. That's probably the biggest thing. And so you figure out what is causing the delirium, and then you treat it, and suddenly they're back to normal, back to baseline. Dementia, like I said before, is more gradual and progressive, and it's chronic and in most cases irreversible. But so there's a big difference, and people get these confused a lot. And but like I said, the main cause for delirium most of the time is usually a UTI. Could be severe constipation, could be something dental, but it's you want to figure out what's going on with that particular patient, so you can figure out, how are we going to help them? How are we going to treat this so that the delirium goes away? And but the biggest key is sudden. It comes on quickly. All right, next slide, please.
Kathy, did you have a question?
Cheryl,
Uh-huh.
Cheryl, well, I've got a Q&A that I wanted to, a question in the Q&A.
Okay.
But I also wanted to stress what you were saying, and can't stress that enough. I know when Catherine and I do the 2-day foundational training, over and over and over, say that if something is acute, happens rapidly, they were functioning fine a few days ago, that
Right.
is it's never dementia. There's something acute going on. It could be delirium, be all other occurring conditions. So I think, and side effects of medications, as you're talking about, one of the major. In the Q&A, in the Q&A, there's a question about what about the medications for people with Down syndrome and dementia. And you maybe have that in a future slide, but I've not seen your future slide, so
You're
I didn't know
talking
if now
about
was the right
you
time for the
mean,
question.
you mean Alzheimer's medications like Aricept and Namenda
Is
for
that
Down syndrome?
Yes. I'll do it exactly. What about meds for dementia with people with Down syndrome?
okay? I have found that, over time, the drugs like Aricept, those just don't work as well. However, we have had great success with Namenda. Namenda helps, mostly with the behaviors, because it just sort of calms the glutamate receptors. Glutamate receptors are responsible for agitation and that kind of thing. It also helps with some cognition, but honestly, the acetylcholinesterase inhibitors just don't seem to help with the Alzheimer's Down syndrome, with Alzheimer's and Down syndrome patients, from what I have seen. Now, other people may have other experiences. Everybody's different, but we have found that, Namenda seems to be the best, seems to do the best job with that patient population. And then also just making sure that you're not adding insult to injury by having them on a bunch of anticholinergic, meds. So you just have to always look at the meds before you're starting them, and try to put them on things that aren't as highly anticholinergic. So you're not going to, last thing you want to do is confuse them more.
And I would just, to add to that, Cheryl, say one of the physicians at the NTG works very closely with is Dr. Brian Chacoin from Illinois, who's really a true expert on Down syndrome and Alzheimer's. And one of the things he has told us on numerous occasions is that he prefers not to use Aricept with his patients with Down syndrome for two reasons. One is the research is not great showing that it does anything, as you found anecdotally, so you're right on target with that. But also because all medications have side effects, and this is the population who tend to be on multiple medications, not all of them, but many of them. And he has a hard time justifying to himself putting an individual on a medication with known side effects if there isn't really good, strong evidence that it's beneficial to them. So just pass
I would
that on.
also like to add to that is that this is research conducted for 10 to 15 years that continues to be replicated. And so there still is not any of the new generation of the drugs that has been shown to be more effective, and with less possibility of side effects. So that's still pretty much the recommendation, is to really try to avoid these medications as much as possible. Though, it's been a long time, just not something new. Thank you, Cheryl.
Exactly. Oh, you're welcome. You're welcome. All right. On to the next slide. Okay. Delirium. Like we said before, there's a little mnemonic called pinch me rather. You want to assess the patient when you think it's delirium. You look at, is it pain? Is it infection? Is it their nutrition? Is it constipation? Is it hydration? Gosh, I can't tell you, in facilities, people just don't get hydrated well enough, and that leads to UTIs in a lot of cases. Is it another medication? Is it the environment and sleep? There can be multiple causes of delirium. And like you said before, Katie, that, when it comes on sudden, it's always delirium. It's never dementia. But these are just some of the common causes of delirium. And we see delirium quite frequently in this patient population.
I would just quickly add to that too. The other thing that we see with delirium is that oftentimes someone will have this sudden change, and the family member or the service provider will call the physician, and the physician will say, oh, it's a progression of their dementia if they already have Alzheimer's or some other, and they just assume it is a progression of their dementia, and delirium never gets looked at. And that's why it's so important for families and service providers to understand this concept of delirium, because I know in my 40 years of doing this, I have seen people that I am absolutely convinced died from becoming septic from urinary tract infections, but it got written off as being, oh, it's just a progression of their dementia. That's what happens with people with dementia. So, just to reinforce what you have said so clearly, if you see that sudden change, it's a medical emergency, and you need to rule out all of these things. And urinary tract infections are certainly the #1 cause. Back when I was in Maine, the head of the Geri Psych unit at Maine Medical Center once told me that of the people admitted through the emergency room at Maine Medical Center for, quote, agitated dementia, 95% of them had urinary tract infections. That's how common it is. But don't stop if it's not a urinary tract infection, as you said. Keep digging, because something's going on there. Thank you.
Oh, you're right though. I can't tell you how many times we see a UTI. And a lot of times, or most of the time, it's due to just improper hydration. All right, and then I'll just talk a little bit about the prescribing cascade, which is basically, you put someone on one drug, and then you have side effects that are interpreted as a new medical condition. So then they put the patient on yet another drug to treat that. And then, it keeps going in this cascade. You keep adding drugs instead of looking at, okay, why are we having this problem? Is it the drug? And maybe they can't handle this drug. Maybe we try a different drug. Maybe we decrease the dose of the drug. It's just that's how patients end up on 20, drugs or more, because we keep adding drugs to treat a side effect. So you're putting a Band-Aid on the problem instead of going back and trying to look at, what is causing the issue. And it's really sad, but it happens a lot. And I see it more probably too when it's, you have multiple doctors, and one isn't, I don't know if they're not, looking at all the total picture, but it sure seems like it, because you might have, like the primary care doc puts them on a particular drug, and then psych adds another, then neuro adds another, then, and suddenly you've got all these drugs that interact as well. So, when you're thinking about meds to put patients on, you have to take a lot of factors into consideration. And a lot of times, in today's world, you have to, I think physicians are forced to see the patient so quickly that they can't look at the total picture always. And so you end up with a big mess. Okay, next slide, please. All right, polypharmacy. So that's where I was headed with the cascade. Polypharmacy. All right, in the IDD aging population, you have high medication rates. So with multiple medications, you're going to have, well, it's because they have more disease states, so yeah, you got to treat these. You got epilepsy, a lot of times you got mental health conditions, other comorbidities, maybe heart issues, kidney issues. So you're treating all these with different drugs. But you're gonna have a higher chance for, well, you are going to have polypharmacy, period. And with polypharmacy, you get increased risk of medication-related harm, higher risk of, drug interactions. Then you also, excessive polypharmacy is really using 10 or more drugs, 10 or more medications. And that includes everything. That includes, even supplements that a patient might take, over-the-counter meds, things that a lot of people don't count, in that when they're looking at drugs, they're looking at prescription drugs, but there's a lot more to it because they all interact with each other. And you just have, like I was saying, it just starts out, with one med, and then you get a side effect, and then you add another med to treat the side effect, and then that one has a side effect, and it just snowballs into just a big mess. So when somebody comes in and they want me to look at the meds for polypharmacy, it's not always an easy task, because you're like, I'm trying to figure out what drugs can we take away, and without knowing the whole picture, like why was this one added, and what happened after it was added, and it's hard sometimes to just sort of look at the med list and try to do figure out how to get rid of some of the meds, because too much, in my opinion, is always worse than not enough when you're talking about medications. All right, next slide, please. All right, then there are also problematic meds in the IDD population. All right, Depakote is one. Before I started doing this, I didn't even know about this, but with Depakote, well, first of all, what is Depakote? Depakote's used for seizures. It's used for bipolar. And some of the usual side effects that you get from Depakote are GI side effects, weight gain, tremors, sedation, low platelet count. So you gotta, do labs to monitor that. Low white cell count, and hair loss. But so this is just a general picture of Depakote. And I think my next slide, if you'll turn to the
And
next
can you
slide.
just give them the generic name for that? 'Cause they may
Depakote,
be-
okay, divalproic acid, or valproic acid. So anyway, so what happens, a big thing though that you can have, we've had patients come into the PDR, and they're on Depakote or valproic acid, and suddenly they're looking like they have dementia. Well, what happens with Depakote, the very first step in the ammonia degradation cycle, which is, happens in the kidneys, that's your body's ability to break down ammonia into urea so you can basically pee it out. Well, this occurs in, we can have in 20 to 50% probably of individuals treated with valproic acid, that very first step in the degradation cycle, and that might be on my next slide, I think. Can you switch to the next slide? Yes, here we go. Okay, this makes more sense. This is showing you the urea cycle. And valproic acid inhibits this enzyme, N-acetylglutamate, which activates another enzyme which helps break down urea, or ammonia. But the problem is this is the very first step in the cycle. So if you end up blocking it, then you're going to get a lot of ammonia in your bloodstream. And ammonia can cause lethargy, can cause problems with gait problems. Suddenly they're not able to walk as well, they're falling, the dementia, confusion. It can cause all these things if you have a buildup of ammonia. I don't know if y'all have ever known anyone who had liver cirrhosis, like the very end cycle or end stages of that. You get hyperammonemia or buildup of ammonia, and so they just really decompensate fast. Well, the Depakote can do this. So what we've done in the past when we've seen this, in PDR, we've either had to decrease the dose, which sometimes will help, but most of the time you have to taper them off the med. And we've had patients that come in and look just horribly, just look like they are just have dementia for sure, take them off the Depakote and it's like a brand new person. They're just bright and, just back to, baseline. But this is something that they didn't teach us in school. I don't know. I don't remember them ever talking about this. I learned this on my own when, taking care of the IDD patient population. And I'm sure it, happens a lot, with elderly folks. So Depakote is a drug, or valproic acid is one you got to be real careful with this age group. Next slide, please. All right. I just talked about this. Basically, I was telling you about a 64-year-old male that we saw in PDR. This is just one example. Down syndrome, had impulse control disorder. That's why he was on the valproic acid. Also had some other comorbidities, sleep apnea, gout, seasonal allergies. But patient was on Depakote ER, 1,000 milligrams in the evening. And then another drug for anxiety, also Buspar twice a day. Then some other meds in addition to that. But he came in with confusion. I mean, it was horrible since it was like we had just started the med, and this was something that he, when we saw him in the last PDR, he was just bright and perfectly normal. And then, so I said, well, let's get an ammonia level and see. The ammonia level was sky high. So we tapered the Depakote and discontinued it. The ammonia level normalized. And he started knitting and enjoying his superhero movies again. So he was like, brand new person. So it's really scary, but this is one you got to watch out for. There are a lot of meds you have to watch out for, but this is one I've learned, just because we have a lot of there are a good many patients on Depakote for mood disorder. And so, if this ever happens and you have a patient that just suddenly decompensates, look at the ammonia level and you may have to get rid of the drug. Another one, phenytoin, Dilantin. Okay, so this is one that has what they call a narrow window of toxicity. So you have to do blood work, and I can't tell you how many times. Like we had a patient that went to the ER and was it was terrible. He was so confused. He was just very unsteady, couldn't walk, well, anyway, his Dilantin level was sky high. And don't even know when they had last looked at it. And so this is one that's really frightening. And honestly, there are so many good new anticonvulsant meds for seizures. This is what phenytoin is for primarily, that I just don't love using this one, but because it is so it's one of those that it depends on how much protein you have in your bloodstream to bind it. And if you have decreased albumin, and a lot of people, if you look at their labs, because of just diet, nutrition, that kind of thing, and aging, albumin level decreases. So that makes them more at risk for having problems with this drug. Anyway, next slide. Okay. Well, and I think I just probably talked about this, and I apologize, I'm getting ahead of myself. But yeah, this was a 31-year-old that we was seen in the ER for a seizure, started on Dilantin ER 100 TID. The serum level was ordered 24 hours later. It was elevated. The med was held for 2 days, then restarted. 1 hour after giving the first dose, the patient just started vomiting severely. He was taken to the ER, and okay, and anyway, it was the Dilantin. So, okay, I'm going to try to get through these. All right, next slide. Problematic meds. Other problematic meds. We hit on these anticholinergic meds. Sedative meds like benzos, you can have falls. That's a big thing. Antipsychotics, they're not without, side effects, weight gain, diabetes, movement disorders. Okay, next slide. Syndromes associated with psychiatric meds. Okay. There's neuromalignant syndrome, anticholinergic syndrome, and serotonin syndrome. These are biggies. A lot of times you see fever, agitation, motor restlessness. But anyway, these all have to be evaluated. These are major side effects. A lot of times it happens when you have people on multiple drugs, multiple antipsychotics, multiple antidepressants. Anyway, all right, next slide. The fatal five. What's the fatal five? Aspiration, dehydration, seizures, constipation, sepsis. Individuals with IDD may have trouble reporting the symptoms of aspiration, dehydration, constipation, other seizures, and or seizures. And that makes it harder and making it more likely that the condition will become severe and lead to a big problem. Next slide. All right. Trazodone. Okay, trazodone is one we've really learned to love using this drug because it's a great alternative, as I was saying earlier, to benzodiazepines. Doesn't have as many side effects, and it's generally benzos are generally not recommended for older adults because it can lead to falls, cognitive impairment, but primarily falls, well, and delirium. So this is one we have found that just is kind of an off-label use, but we use it a lot in low doses. So we might, use this like 25 milligrams once a day to start, if for anxiety, maybe 25 milligrams twice a day, 3 times a day, going up on the dose as you need to. But it works well at low doses. Next slide, please. All right. Namenda, I think I hit on this one earlier too. We've learned to love Namenda. It works great. Honestly, in our autistic population. And I think I have a case study on that next. If you go to the next slide. Yeah. There we go. No, where was it? Okay. Yeah. All right. Yeah. Anyway, next slide. I think I've got a case study. Okay. Yeah. This was a fella who came in and, he was just, honestly, he was beating the crap out of everyone. No one wanted to work at the house. They were about to get evicted from the whole neighborhood because of all the behaviors he was having. And it was in PDR one day, and it broke my heart. He started just beating his mom up. And so the police had to eventually be called to help de-escalate everything. And so I was in the room with mom while the psychiatrist was in the room with the patient. And she said to me, she said, this is so sad. He used to be such a sweet autistic kid before COVID. And so I thought, what? Okay. So I started doing some reading and, everyone, I don't know if y'all have heard the term long COVID, but with autistic folks, it really can cause a lot of problems. Uh, anyway, and our IDD patient population in general makes it harder for them to concentrate. But most of all, what it does is it leads to higher glutamate levels. Glutamate is that causes shoot, I'm losing my train of thought. But anyway, glutamate leads to agitation. Basically, it's what's responsible for agitation in most patients. And so that's why we if you go to the next slide, I think I have more about this. Yeah. Okay. So, and I just talked about this. Sorry, I'm getting ahead of myself. Next slide, please. Anyway, we decided we would try Namenda with him because I did a bunch of reading and discovered that this was something that they were using, and it's because of Namenda's ability to kind of calm that overexcitatory glutamate. And so what happens is then the patient calms down. And boy, it took a while to work on the psychiatrist to get him to try this. I mean, we went through, oh my gosh, you can see multiple psych meds, and nothing was helping. Put him on the Namenda. Next time we saw him, it was like brand new person. He was back to, I mean, his mom said, oh my gosh, he hasn't been this sweet in forever. And so it was almost like a miracle. But so we use Namenda a good bit. Next slide, please. Okay, and this is in summary. All right. Just wanted to give you a few terms of how things, how meds are, just the pharmacokinetics and pharmacodynamics of a drug. Wanted to talk about acute versus chronic side effects, like or acute versus chronic, mostly with delirium and dementia, polypharmacy, problematic meds, the fatal five. It's hard to hit on everything in an hour, but there are so many things, just in summary, that you have to consider when you're taking care of aging population. Drugs just don't affect the aging population like they do the younger folks. I hope I left time for questions.
And I've got a quick question for
Okay.
you. You've touched on a lot of my questions, and this is one of my favorite topics, but there are, for many medications, geriatric dosages. And you've talked about the fact that as the body ages, we don't process meds as efficiently and so forth. But yet, the people I work with, I rarely, frankly, never see medications that they are on ever reduced to a geriatric dose as they get older. It's the same dose they were put on years ago. And as you know, clinical trials are done on, healthier, younger people and not people with IDD. Could you speak just a bit to geriatric dosages? And is this something that providers and family caregivers ought to be considering bringing up either with their physician or pharmacist?
Well, yeah, you're right, because as people age, you do need to look at decreasing the doses of the meds. And also, if they have decreased kidney function, there are dosages for, different dosages for kidney function, or decreased kidney function, than someone who has normal kidney function. But yeah, there are, and sometimes it's just more of like a common sense kind of thing, you just start, and we do it really well, I feel like, in our facilities with psych, because you're kind of forced to, because DHEC, or now they're called Department of Public Health in our state, but they want you to do gradual dose reductions, once a year. So that's a good thing, because it does force us to look at, sometimes, honestly, even this is kind of a side topic, but we find that, the patient was maybe put on this med for the wrong reason in the first place. So when you're decreasing it and they're doing well, and then suddenly you're like, well, okay, let's try to take them off of it and see how they do. And that can happen with elderly folks too. I mean, with other meds, I mean, like blood pressure meds, no, you're probably never going to get rid of it, or diabetic meds, but you can a lot of times, because things change as people get older. You may need a higher dose, but a lot of times a lower dose. It just depends on the med, but and the state of the organs, the kidney, the liver, that kind of thing with the patients. But yes, there are, to answer your question, there are different dosages for geriatric.
Kathy, I'm going to turn it over to you.
Okay.
I just want to say one thing in regards to that, and then I'll turn it over to you for the closing thought.
Thank you.
But the thing that really impressed me about medications and these sorts of issues was a family member in Texas who her sister had this precipitous decline to the point where she wasn't eating anymore. She couldn't walk anymore, was bedridden, was told by the physician that she was in the terminal stages, the end stages of her, of dementia. She went on hospice. Well, of course, what's the first thing hospice does? They review all the meds and they take you off meds that aren't necessary for anything other than comfort and so forth. Well, guess what happened to her? All of a sudden, she started to eat again and drink again and be able to move around again, and went off of hospice and ultimately went home. And that, to me, was a tale of caution for medications. I know we've gone over, but this is such an important topic. Kathy, you want to bring us home?
Yeah, I'd like to add to that because
I'm going to put up the survey also. While
perfect. Thank you. I have found where it's all or nothing for older people. There are times that they will take them off that annual review. It's like take them off everything, and that can be equally catastrophic of never removing. I think this is another topic that I really think we should return back to. Hopefully you'd be willing. We have some lunch and learns left, and I think it would be a great follow-up to go into detail about some of the things you can do with meds and giving some really good practical information. It's been a pleasure. And it's been a pleasure. We appreciate everyone who's been on. Of course, appreciate Cheryl and the excellent presentation, such a needed presentation. We hope you will be with us next month with the Texas Lunch and Learn. And Catherine, I don't have the date in front of me. Do you?
I do. It is December 16th. And I think we're going to be talking about action plans with Sharon DeBova, but we're waiting on a commitment from that.
Perfect. Great. Oh, that will be
and don't
great.
forget to take a moment to complete the TCDD survey. We want to thank our funder, the Texas Council for Developmental Disabilities. If you could just take a minute, use your little smartphone there to scan that QR code. I think it's also going to come up in a separate pop-up window in your browser when we end the webinar, but please just take a minute and fill that out for them. They'd appreciate it.
And to thank the grantee, the primary grantee, the University of Texas Health at Houston. Cameron hasn't, we haven't heard from Cameron, but has been on. And it's great. Great to see you, Cameron.
There she is.
There she is. Go ahead, Cameron. You're waving, but would you like to say anything as we close?
Oh, you're muted.
You're muted. You're muted.
Greetings to everyone. Thank you for a wonderful session, and I encourage you to tune in for our future Texas Lunch and Learns.
Thank you. And the National Task Group on ID and Dementia Practices really thanks all of you for including us in the learning in Texas. We have learned from you, and we are always honored to share what learning and the people that we know that have so much to give, like Cheryl, that can make a positive difference. So thank you to every one of you. We really appreciate it. And we'll see you next month on December 16th, we hope.
Thanks, everybody. Thanks again, Cheryl.
All right, you're welcome.
Thank you.